Hi, and welcome to Falcon Physician Reviews. My name is Dan Yano, and I'm a neurologist working in Chicago. We'll be going through several modules to discuss cellular physiology. Our first module will go over body fluids. In this next section, we'll cover body fluids. Water comprises approximately 70% of our total body weight, and that water is distributed across three separate compartments: the blood compartment, the interstitial compartment, and the intracellular compartment. The blood compartment contains the fluid within our vascular system. The interstitial compartment comprises the fluid that is found within tissues but outside of cells, whereas the intracellular compartment comprises all the fluid that is inside of cells. The fluid is distributed asymmetrically across these three different compartments. The vast majority, 60 to 70% of the fluid, is found in the intracellular compartment. Approximately 30 to 40% is found extracellularly, and that fluid is distributed across the interstitial compartment and the plasma compartment. The plasma compartment contains about 5 to 10% of our total body fluid, and the remaining 25% is found in the interstitial space. That is the space that is outside of cells but within body organs. There are several membranes that separate these various compartments. So the membrane that separates the interstitial compartment from the intracellular compartment is referred to as the cell membrane, and we'll speak about this in more detail as the lecture continues. And the membrane that separates the interstitial compartment from the plasma compartment is the capillary wall, and that will be the focus of the next series of slides. Capillaries have very specific roles. Their major role is to allow the exchange of both fluid and nutrients between the vascular compartment and the interstitial space. Capillaries, by definition, contain a single endothelial layer. And this endothelial layer can have gaps between one cell and the adjacent cell, and these gaps are referred to as fenestrations or fenestrae, shown here on the left of this diagram. We can look at a schematic view of a segment of capillary as shown on the right, and every capillary will have an arterial end and a venous end. That is, the arterial end is the portion of the capillary that receives oxygenated blood from the arterial system, and the venous end contains primarily deoxygenated blood, which will feed back into the greater venous tree. There are several forces that will influence the movement of fluid across the capillary. The two major forces are the hydrostatic force and the oncotic force. The hydrostatic force is symbolized with the capital letter P, and this hydrostatic force is the force exerted on a capillary wall by the physical pressure of water inside of that capillary. P sub C refers to the physical pressure or the hydrostatic pressure within the capillary, and P sub I refers to the pressure in the interstitial space. Typically, the pressure inside the capillary greatly exceeds the pressure in the interstitial space. That is because this pressure is generated by the beating force of the left ventricle, and that force is then transmitted throughout the rest of the vascular tree. Early in the course of blood flow through a segment of a capillary, P sub C is substantially greater than P sub I because no fluid has been lost across the capillary wall or the capillary membrane. But because capillaries have fenestrations, and these fenestrations allow fluid to move through those openings, as fluid is lost throughout the course of the capillary, the pressure, the hydrostatic pressure inside that capillary decreases along the length of that capillary. Water, in other words, is distributed from the intravascular compartment into the interstitial compartment. And as this occurs, P sub C, the pressure inside the capillary, will decrease, and P sub I, the pressure in the interstitial space, will increase. And therefore, the filtration gradient, or the difference in pressure between P sub C and P sub I, will decrease along the course of the capillary. And that's shown on the top right of this figure. Early in the course of blood flow through the capillary, this filtration gradient is high, and as blood flows through the capillary and as fluid is lost, that filtration gradient decreases. An additional force which influences the flow of water across the capillary membrane is the oncotic force. The oncotic force is an osmotic force that draws fluid down its osmotic gradient. The difference between the oncotic force and osmotic force is that the oncotic force only refers to those molecules that are asymmetrically distributed across a capillary membrane. That is, those molecules that are too large to pass through the fenestrations. This typically refers to proteins, polysaccharides, and depending on the actual capillary, sometimes smaller molecules as well. Early in the course of blood flow through a segment of capillary, the oncotic pressure inside the capillary is relatively low. As fluid flows out of the capillary along the length of this capillary, the oncotic pressure begins to increase. This is because fluid is lost across the capillary membrane and the relative concentrations of proteins and other large molecules inside this capillary increases. We represent the oncotic pressure with the variable pi, and pi sub c refers to the oncotic pressure inside the capillary, pi sub I refers to the oncotic pressure outside of the capillary, and as blood flows across this capillary membrane, the difference of pi sub c and pi sub I increases. Therefore, along the course of the capillary, there is a tendency for water to come back into the capillary, driven by this increase in the gradient of pi sub c minus pi sub I, and that's shown on the right side of this diagram under oncotic gradient. Over the course of the capillary, this oncotic gradient increases. Another way of expressing these relationships is shown at the bottom of the slide. This equation relates the hydrostatic force to the oncotic force. The hydrostatic force is expressed as P sub c minus P sub I, and the oncotic force is expressed as pi sub c minus pi sub I. These two variables are related by the coefficient shown here as alpha, the reflection coefficient. The reflection coefficient corresponds to the leakiness of a particular capillary membrane. Certain capillary membranes are leakier than others, and the leakier the membrane is, the more that small molecules can distribute across that membrane. Certain capillary beds are quite leaky, such as the glomerular membrane, and when that's the case, there is less of an oncotic gradient across that capillary membrane, and the reflection coefficient alpha becomes close to its theoretical minimum of 0. Other capillary membranes are much less leaky, such as those found in the blood-brain barrier. There, the asymmetry in medium to large-sized molecules is much larger across that capillary membrane. Therefore, the reflection coefficient alpha approaches its theoretical maximum, which would be 1. There are several clinical examples when these relationships are broken down and there is an asymmetry of water distribution across a capillary membrane. One example is found in nephrotic syndrome. During nephrotic syndrome, there is glomerular damage leading to the loss of protein in the urine or proteinuria. Ultimately, this leads to loss of albumin in the blood or hypoalbuminemia that will decrease the oncotic pressure inside the vascular system. As we learned in the previous slide, the intravascular oncotic pressure, or pi sub c, is one of the major forces drawing water back into the capillary. Therefore, as the oncotic pressure decreases, less water is brought back into the capillary, and this ultimately leads to edema, as shown here on the right, a patient who has pedal edema due to hypoalbuminemia driven by nephrotic syndrome. Another example of the asymmetry of water distribution across a capillary bed is found during congestive heart failure. Shown on the left is a chest x-ray of a patient with the typical findings in somebody with congestive heart failure. Notice that there's blunting of the costophrenic angles, and there is cephalization of the vasculature surrounding the heart, all of which pointing to fluid overload. The fluid overload in this case is caused by left ventricular failure. During left ventricular failure, blood cannot be adequately ejected from the left ventricle. This increases the pressure inside the vascular system, and that backup and increase in pressure will increase P sub c. And as we learned previously, an increase in P sub C will increase the hydrostatic force pushing fluid out of a capillary, and this will lead to an excess of fluid buildup in the interstitial space, in the pulmonary system. The other major manifestation of congestive heart failure is peripheral edema, and this occurs for the same reason. When there is right heart failure, there is an increase in P sub C throughout the venous system. As P sub C increases, the hydrostatic force driving fluid out of a capillary also increases, leading to fluid buildup or edema in peripheral tissues. Another example when there is a misdistribution or a maldistribution of fluid across a capillary bed is in hypertensive encephalopathy. In hypertensive encephalopathy, the primary driving pathological feature is an increase in blood pressure. These very high increases in blood pressure will increase P sub C, the hydrostatic force inside a capillary bed. As P sub C increases, as we discussed in the previous slide, this will drive fluid out of the capillaries and into the interstitial space. In this particular example, the interstitial space that's affected is in the posterior regions of the brain. And as shown here, there is edema, shown with a white signal, in the posterior regions of the brain. The typical clinical manifestations of this kind of clinical issue would be headache, confusion, and loss of vision. We will now go through two vignettes which describe the misdistribution of water across a capillary membrane. A 75-year-old man with severe chronic obstructive pulmonary disease, type 2 diabetes, hypertension, and dyslipidemia walks into the VA emergency department with dyspnea on exertion and says, "Doc, I'm having another COPD flare." Exam reveals bibasilar crackles, expiratory wheezing, increased jugulovenous distension, and dependent edema. What is your diagnosis? In this case, this patient's exam reveals fluid in various places. The bibasilar crackles refer to fluid found throughout the pulmonary system, particularly in the alveoli, and when they open against the surface tension created by that fluid, one can hear crackles upon auscultation. Expiratory wheezing is found whenever there is narrowing of the airways due to inflammation, which is what we typically think about in terms of another disease like asthma or COPD, or whether or not there's fluid buildup in the interstitial space. Jugulovenous distension is another indirect measurement of fluid overload. One can observe distension in the internal jugular system when a patient is fluid overloaded. And dependent edema, as we've already discussed, is related to the increase in P sub C, driving fluid out of the vascular system and into the peripheral tissues. Your next patient has end-stage hepatitis C and comes in with increasing abdominal girth, and you do a 4-liter abdominal paracentesis. What is your next move to prevent the rapid recurrence of ascites? Well, it's important to remember what the cause of ascites is in this patient to begin with. One of the major driving forces for ascites in patients with liver failure is the low production of albumin by the liver. This will drop P sub C, lowering the oncotic pressure, causing edema to form. The other major factor influencing the particular localization of edema in these patients is the increase in portal pressure. This portal hypertension is going to increase P sub C in the vascular beds that feed into the liver. As P sub C increases, this will also drive fluid out of the capillary beds and into the interstitial fluid, creating the ascites that is very typical of this clinical condition. One thing that can be done to prevent the rapid recurrence of ascites is to provide a replacement source of albumin. And this albumin will maintain the fluid in the vascular system for a longer period of time than what would have happened if the subject was not given this medication. That concludes this section on body fluids. In the next section, we'll move on to membrane physiology and talk about the distribution of molecules across a membrane and how that distribution is regulated. That concludes this section on body fluids. In our next section, we'll discuss cell membranes.